to the Home of Medicine podcast with me, Dr. Amy Burbridge. I'm a consultant in the West Midlands in the United Kingdom.
And hi, I'm Ben Lovell. I'm also a consultant in acute medicine and I work in London in the UK.
So Ben, I've got a case for you today. Are you ready?
Yes, I'm ready.
So I was doing a post-take ward round last year and I saw an 18-year-old male who presented with a headache. He said the headache was worse in the morning and got better throughout the day, and this had been present for 12 days. He also said he had a bit of a fever at night, but didn't really feel feverish during the day, and he hadn't checked his temperature at home. He denied any of the symptoms, really. He just said he felt a bit achy, joints felt a bit sore, hadn't really felt sick. His appetite was a little bit off, hadn't been eating as much as normal. But apart from that, nothing specific. This was before any more specific questions were asked by the clerking doctors. So all we had really was an 18-year-old male with a morning headache and a night fever. Any thoughts? So I know that's a very little information.
I have thoughts. Don't worry, I still have thoughts.
Okay, excellent.
So 12 days of headache.
Yeah.
We don't know what the onset was like. I feel like you would have mentioned it if it was a thunderclap onset, which would send us down quite a different pathway if this is a subarachnoid hemorrhage. Is it a vascular event?
Okay.
But 12 days of headache, worse in the morning. Now, worse in the morning flags up to me. It's one of the things I have filed in my brain under mass effect, space occupying lesion. So if you have mass effect in your brain, it gives you a headache, and the headache tends to be worse in the morning. It tends to be worse when you do Valsalva maneuvers, coughing, sneezing, straining. Sometimes it wakes you up at night. So 12 days is a short history if there was a slow growing mass in the brain, but I would investigate more to see if there were any other features of a high pressure headache to go along with this.
Okay, excellent thought.
My other thought is felt feverish overnight. I never really know where to park that because I often get told, oh, and the patient also has been having fevers. And when I say what they've actually been measuring their temperature at home, well, no, they just felt very hot. And I don't really know. I mean, that's not a fever, right? A fever is when you put a thermometer in an orifice or an armpit and you get a number. And I think with a lot of disease processes, you can feel very hot and unwell. It doesn't necessarily mean you've spiked a temperature, i.e. your immune system has been activated. So I would be interested to know whether there was any quantitative evidence of a fever or he just felt very hot and unwell. So at the moment, I'm thinking between high pressure headache, need to ask more questions, felt feverish. Could this simply be a virus? You said he felt achy and sore. A lot of viruses going around. Is this just part of a flu-like illness which will come and go, and we need not do much more investigation based on that. So that's my mental landscape right now based on that data.
Okay, excellent. So what I just want to drill down a little bit is, what specific questions would you like to ask about the high pressure headache?
So high pressure headache, insidious onset. Is it getting slowly worse day after day? Something is increasing in pressure day after day inside the brain. It's worse in the morning. Does it make you queasy? Does it make you vomit? Does it get worse when you're straining, coughing, sneezing? Does it wake you up at night? A headache should not normally wake you up. Like a good old fashioned tension headache is miserable, but you shouldn't wake up with pain with it. Any vision changes? Is there compression inside to the back of the eye? So is there an optic nerve swelling? Any other neurological symptoms? Is there a false localizing sign such as a sixth nerve palsy? Have they noticed double vision? So that's the sort of questions I ask for high pressure features.
Okay, so still quite wide type of questions then, aren't they? Okay, excellent. So to give you a little bit more information then, he hadn't had any vomiting. The headache wasn't waking him up at night, and he was sleeping okay. He didn't notice that the headache got worse on straining, although moving just was really difficult because it just made him feel maybe a little bit dizzy. And the headache didn't necessarily get worse, but he just felt weird. Just didn't quite feel right. There were no visual disturbances noted, and he hadn't noticed any weakness in the face or any cranial nerve changes that would be suggestive of a false localizing sign.
Mostly reassuring then, isn't it?
Yeah.
Because we have to make a decision at some point as a doctor about whether we're going to scan him or not.
Exactly.
So any cross-sectional imaging to look for a mass. So at the moment, not very compelling evidence to put him through the CT machine. We need a bit more information.
Okay, yeah, so I've got a little bit more information for you then. So we asked him about his bowels, Bowels hadn't been open for 4 days, but he hadn't been eating as much. And he said, well, I've not been eating as much really. Normally his bowels opened once a day, and that was normal. He denied diarrhea, and the last time he opened his bowels 4 days previously was a normal motion. His bladder, his bowels and bladder, sorry, his bladder was normal. He denied any dysuria. He said that he'd been drinking less. His urine was a little bit dark, but when I asked him, is it really smelly? He said, well, I didn't really check, but it wasn't something that he'd particularly noticed. He'd had no rashes that he'd complained of. He said that he felt a bit weird, a little bit confused. And when we tried to delve down into that a little bit more, he said, just not right. Just can't put my finger on it, but something just doesn't feel right. And when I did a mini ment, sort of, do you know where you are? What's the date today? What's your name? Where do you live? What's your date of birth? He could answer all of them. So his GCS, when I saw him, was 15 out of 15. There was nobody with him for me to be able to get a collateral history at that moment to delve down a little bit more into that. And the other thing he complained of was just this widespread aches and pains. And that was it, really. There was no chest pain, no shortness of breath, no cough, no wheeze, no hemoptysis, no palpitations. He said that his joints were achy and his body was generally a little bit achy, but there was no sort of abdominal pain in specific areas, no indigestion, nothing really. No night
Okay.
sweats.
So when I assess headaches, and we've done
Yeah,
this before, and the
yeah,
podcast episode is probably called headache. But I have a 4-step way of assessing a headache, and the first step is always, is this a serious secondary headache?
yeah.
And I do serious secondary headaches first because they're the ones that are life altering or life limiting. And my big serious secondary headaches are hemorrhage, so a subarach or a subdural. It doesn't smell like that in the slightest. Subarach gives you a very profound sudden onset headache. And the other serious secondary headache is a CNS infection. So we're talking meningitis. Okay, so meningitis gives you a headache because your meninges are inflamed. The other one we talk about is encephalitis. Encephalitis shouldn't give you a headache because there are no nerve endings in the brain tissue, but it can cause personality change, motor problems, sensory problems, even seizures. And you can see it in the context of someone having a prodrome of a flu-like illness. There is a very nebulous diagnosis between them, which I hear get thrown around by ID doctors, called meningoencephalitis, a little bit of one and a little bit of the other. And that sort of allows the patient to have a headache as well as the viral encephalitis. I'm talking about viral meningitis and viral encephalitis because, to be clear, meningitis is either bacterial or viral, but encephalitis is a viral thing. So CNS infection as a secondary cause, potentially. So what I want to see is, what's his fever, what's his inflammatory markers in a full neurological examination, and has he got any hepatic sores on his lip, which might predispose to HSV encephalitis. So then my serious secondary headaches I want to screen for first of all. And if they haven't got anything, then I'll move on to stage 2 of my assessment, which is always, have they got a non-serious secondary headache? And they're sort of TMJ dysfunction, medication overuse headaches, sinusitis, dental pain, ear infection. They're quite easy to sort out. So there's step 1 and step 2. And then step 3 is, do they have a primary headache disorder, migraine or tension type headache? Don't reach for that diagnosis from the first shelf usually until you've done steps 1 and step 2. And then finally, final step is, if you haven't got any of those, have they got something fun, like a trigeminal headache, an autonomic headache, which would be cluster headache. Cluster headache does predispose towards young men, but you haven't told me that he's got a streaming eye, he's howling in pain, he's got ptosis, he's got conjunctival injection. So that doesn't sound right at all. So let's stick with step 1, serious secondary headache. Have we ruled out CNS mass, CNS high pressure, or CNS infection?
Okay, excellent. Yeah, so I agree. Is this a CNS infection? Is it a mass? So, but I'm going to give you a little bit more information first. Okay, so he had no past medical history of note. He didn't take any medication. He smoked about 20 cigarettes a day, but he denied any illicit drug use. He was currently not working, and that had been for about 2 to 3 months. But that wasn't due to the headaches or anything else. He just couldn't find work. On examination, his heart rate was 110 beats per minute. His blood pressure was 130 over 72. His temperature was 37.9. He had palpable lymph nodes in the mandibular region, the submental region, the axilla, and the groin. Now, when I palpate lymph nodes and I can feel them in the mandibular region and the submental region, that prompts me to then palpate for lymph nodes in the axilla and the groin. If I don't feel any lymph nodes in the mandibular region, the submental region, I wouldn't necessarily and automatically palpate in the axilla and the groin unless there was something in the history that prompted me to say that I needed to do that. His abdomen was soft and non-tender. There was no hepatosplenomegaly that I noted. And he had a weird rash on the left side of his chest. It was a dry, itchy rash. And when questioned about this, he said, oh, that's been there for 2 years. My local doctor, my GP's seen the rash, not worried about it. I asked him if it had changed. He said no. It looked very much like a dermatitis type picture that he'd scratched at and it was itchy, but it didn't look infected. His chest was clear, heart sounds were normal. His calves were tender, but they were soft and there was both calves were tender and there was no pedal edema. And when I touched his muscles, so I always think if I'm worried about the fever now and he's got some lymph nodes, I was sort of feeling his muscles and they weren't tender anywhere else. He just said his calves were a little bit sore. That's his examination findings. Anything else you'd like to know at this point?
So starting to get a bit more worried about this young man.
Okay.
He has,
Why?
because he it has lymph nodes everywhere,
Yeah.
a fever and a rash,
Yeah.
and some night warmth. And
Mm.
now I am now wondering whether he's got some kind of hematological malignancy, such as lymphoma.
Okay.
Um, I'm still thinking infective versus hematological,
Yeah.
because you can get widespread lymph nodes and a fever with Epstein-Barr, EBV, or
Yeah.
CMV infection. That can also give you headache, usually a pretty dramatic sore throat as well. But it certainly needs to have a glandular fever screen as part of his workup. But
Hmm.
I have seen lymphoma present with a headache, first of all, sometimes in the context of hypercalcemia. And this is now what I'm starting to worry about. So where I would sit now, as I would need to get some blood test results, I would looking at his inflammatory markers. I would want a blood film as well as a full blood count, blood cultures. I want a glandular fever screen, LFTs, and a bone profile. And I would be starting to wonder about whether we have to do some cross-sectional imaging, not just of his head, but of his abdo-pelvis, his chest abdo-pelvis, looking for widespread lymphadenopathy, and eventually is there one that's amenable to a biopsy if we have to go that far down? Because what I'm thinking is these nocturnal fevers he's been reporting and this itchy rash, are these now B symptoms, constitutional symptoms of a hematological malignancy? So that's what set off an alarm bell for me. And that's why I suddenly shifted and reframed from CNS infection to something a bit more widespread.
What piece of information made you go, oh, and start to worry about lymphoma?
It was the lymph nodes, the widespread
Okay.
lymphadenopathy. So with
Okay.
EBV and CMV infections, you can get quite dramatic splenomegaly. You said he didn't have that, but
No.
you can get quite bad submandibular lymphadenopathy. You
Hmm.
could get widespread lymphadenopathy, but it just is, I think it makes it slightly more likely to me to be a widespread hematological problem rather than a viral infective problem. So it was the lymph nodes everywhere, you've said. He's tachycardic, he's
Yeah.
febrile, he's got a rash as well as a headache. Tender calves, I haven't quite pieced that into the whole jigsaw
Mhm.
yet.
Yeah. Okay. So, what would you like to know first?
Full blood count.
Okay. So his hemoglobin was 168.
Mm-hmm.
His white cell count was 11.4,
Mm,
with a normal lymphocyte count and normal neutrophil count.
okay.
His platelets were 345.
Yeah.
Anything worry
Okay.
you in there?
His HB is slightly up.
Yeah.
He's a young guy. You can see that sometimes with hemoconcentration and dehydration, the HB goes up, but it's not sort of pathologically high to my mind. Okay. What about his renal function? Is
Normal.
using his normal? Any other blood test on his biochemistry that pinged?
No.
Okay.
Or CRP was 28.
Okay. So LFT and bone is okay.
So, now I'm going to tell you his liver function tests now.
Mm-hmm.
Okay. His bilirubin, 265.
Right. Billy 265. Okay.
Alk Phos, 482.
482. Yep.
ALT, 711.
Okay. That's interesting. All right.
Hmm.
Where does that put us? Gosh, but you can get fantastically deranged LFTs with Epstein-Barr and CMV. You can.
You
You can
can.
get really, really deranged ones. The ALT being 700, when it gets to 1,000, in my mind, that speaks to me of either toxins like paracetamol or a viral infection, hepatitis A, B, C, D, E, all the way up, or CMV, EBV. So he needs a full liver screen. The
He
Billy
does.
265.
Mm.
Did he look yellow? That's really high.
Really high. So we looked at this and went, oh my God, how did you not notice his jaundice?
Yeah.
And we went back to see him and we're like, oh my God, of course he's jaundice. But it's one of those things, and I'm going to blame my poor clinical examination here, but also sometimes the lighting.
Did you have the
Um,
light switched off?
yes. Do you know, so often I'll walk into the ward and there are no lights on. And sometimes it's really important to simple things like turn the light on, um,
Mm,
which sounds crazy, particularly if you see them in the morning and the lights have been switched off overnight. And particularly if they're not near a window and there's no natural light. So
mm.
switch the lights on and we had a good look at him and you're like, oh, yeah, you're very jaundiced. And we'd missed it. And I wonder if we'd missed it because we weren't looking for it. And that often happens, doesn't it, if you're not looking for it? But I would have thought as a bilirubin of 265 that this gentleman would be incredibly yellow, but he wasn't actually. When we looked at his eyes, it was obviously that he was icteric, but we hadn't picked it up initially. But apart from that, we didn't really notice it too much.
It's true what you say about the lighting, because when I do my ward rounds on AMU, we start at 7:30, 8 a.m. I'm waking patients up. So they're all
Yes.
confused and bleary-eyed and suddenly desperate for the loo. But B, the lights aren't on yet. And I'm often doing it in semi-darkness. And I'm being guided by the examination findings from the clerking doctor, which may have been a good few hours ago now. But I'll examine the patient. But I haven't always got the lights on. Half the bedside lights don't work. You don't want to switch all the lights on in the bay because everyone then gets the hump on because it's 7:30 in the morning and they've only went to bed 2 hours ago because they were stuck in a corridor for hours and all that sort of thing, all these human factors. But you're right. I remember going to a dermatology clinic in my training, and I examined the patient's skin and basically just had a look at it. And the consultant went, "No, no, no, no! When you're doing skin examinations, turn the light on." And he got this sort of a lighter, an actual like a flashlight thing, and made the patient like strip from the waist up, and then actually moved the torch all over his every square centimeter of the skin, looking and looking and looking. And I'd never seen anyone look at the skin in that much detail before. Now, I'm not saying we shine a light on torch on all our patients when we examine them, but it's interesting that we do often on the fly in acute and emergency medicine examine patients in semi-darkness.
Yeah,
What are we missing?
I know. And that made me think, how many things have I missed previously because I didn't switch the light on? You know, something so simple and so easy to remedy. So now I switch every single light on and it's like the illuminations in the ward because I'm
Mm.
so petrified of like, oh, what I could be missing. But yes, on reflection, he was incredibly jaundiced. So we've got this gentleman who's 18, headache, fever, lymph nodes,
Mm,
jaundice.
mm,
You mentioned EBV, you mentioned
mm.
CBV
Yeah.
and hepatitis. Are there any other questions now that you want to go back and ask him in the view of these liver function tests?
So, okay, so I'm going to work through my liver derangement. So, infection, viruses. Okay, we don't know there's any high risk behavior for blood-borne viruses, but
Hmm.
we will ask him.
Okay.
And this is high risk sexual or drug taking behavior. And we're going to do a full liver viral screen, including HIV, EBV, CMV, and all the hepatitis viruses.
Yeah.
Also, ask about travel. I saw a horrendous case of Hep A come back from abroad, from Brazil, I think, or something. So a travel history is part of the infection screen as well. So that's my virals. Structural problems. He's definitely going to need some imaging.
Okay.
Do we do a CT chest abdo-pelvis because we're looking at everything? We know that CT is not the best modality for looking at the liver. Do we want an ultrasound scan of the liver and the biliary tree first instance and see whether there is an easy pathology there to identify before we move on to larger cross-section imaging that involves ionizing radiation?
Hmm.
So we're going to do that. In terms of other things that we do for part of our liver workup, we autoantibodies, but he's the wrong demographic really to have autoimmune hepatitis, to have sclerosing cholangitis. He doesn't have any IBD that might make him more likely to have any autoimmune liver disease that we know of.
Hmm.
You mentioned his bowels have been a bit funny for a few days, didn't you?
Hmm. Yeah.
Usually it's people with established ulcerative colitis who then
Yeah.
get sclerosing cholangitis on top of that.
Yeah.
The bilirubin will be making him itchy.
Yeah.
Maybe that's why he's scratching and scratching and he's got that rash. And that's where I stand at the moment. You're asking me, there's a question I want to ask him. Let me think. Um, No, apart from the ones I mentioned already, but I
Okay.
can't think of a specific question right now.
So you mentioned travel. You
Oh.
mentioned any risky sexual activities,
Mm.
tattoos.
Tattoos, needle sharing,
Needles.
yeah,
Exactly.
blood transfusions in the past, as unlikely as that would be. Yeah.
Yeah, so he hadn't had any recent tattoos, but he had recently traveled to the Indian subcontinent.
Mm,
And that was where his family were originally from. He'd
right.
returned home about a month previously,
Okay.
and had got home and had been working, had just been working, well, not as normal, back to his normal self.
Mm. So that's going to come up as, and I'm trying to think what else infection wise that could be apart from all the viral
Yeah.
hepatitis. I don't believe yellow fever is endemic there. I'm thinking more South America for that.
Mm.
Um, yeah.
Does that change your way of thinking again, knowing that it's travelled?
Well, I often tie travel history with this specialty of infectious diseases.
Yeah.
So it does make me lean, it does make me wonder about
Okay.
what infection, what are we missing here? What it
Yeah.
could be an infective thing. Yeah.
Yeah, absolutely. So we talked about intrahepatic, we talked about posthepatic causes. Are there any prehepatic causes of jaundice that you'd want to rule out in this gentleman?
Well, if he was hemolyzing, I mean,
Yeah.
you could do a split bilirubin and see whether this bilirubin was
Yeah.
all conjugated or unconjugated. The rest of the LFTs being deranged means I would be very surprised if it was all unconjugated bilirubin because he was hemolyzing.
Mm,
Is way too high to be Gilbert syndrome, which I've never seen hit that high before and should not
no,
make you ill, feel
no.
constitutionally unwell. And other any kind of hemolysis syndrome will give you a raised bilirubin,
Yeah.
G6PD, spherocytosis, anything like that. But why would he be hemolyzing now? Could he be hemolyzing in the context of acute infection, acute viral infection? I guess it's the one way that the split bilirubin might be useful.
Okay, yeah. I mean, we did a blood film. Blood film was normal.
Mm,
So there was no hereditary spherocytosis, hereditary elliptocytosis. There was no history of sickle cell in the family. So it
mm,
didn't feel like that would fit. But you're absolutely right. These are the sort of things that you go through your head. And certainly when I see a patient who's jaundice, I go back to medical school and I'm like, prehepatic causes, intrahepatic causes, and posthepatic causes, and do exactly what you've done and try and think about the causes in each section and what investigations I need to do. I know that's probably quite old fashioned now, and I'm not sure whether that's what medical students do these days. But for me, I sometimes like to go back to traditional ways of trying to work things out, really going back to basics, thinking about the physiology and the anatomy for the different causes of jaundice in this gentleman. I agree with
mm.
you. They sounded quite intrahepatic, didn't it? He had a very hepatic picture. So, and also, you mentioned lymphoma. Where are your thoughts with that now?
I think at the moment I'm thinking about about ruling out infectious diseases first. I mean, a big one I haven't mentioned is malaria, which can cause hemolysis and
Yes.
fever and
Okay.
headaches. So, did he go to endemic area and did he take any malaria prophylaxis whilst he was there? Would be another big question, of course. And that blood test would
Brilliant.
be doing a blood film, but and a parasitemia screen as well. So, and I'm trying to think, does dengue cause such deranged lymph LFTs and lymphadenopathy? Dengue you can cause a horrendous headache. And I
Yes.
think you can get, but you tend to be associated with low platelets, and his are not low. And I think you can get deranged LFTs, but I don't know if it's associated with lymphadenopathy though.
Yeah, absolutely. So I'm so glad you brought up malaria because that's something that we often don't think about because maybe we don't see it very often. But absolutely, anybody who has abnormal LFTs, a headache, and a fever, travel abroad, think malaria. That's so, so important. And to get the appropriate investigations, because when you've got that diagnosis, it's really important to know, are they going to need admission? Can we treat them as an outpatient? Is it falciparum? Is the headache because they've got central nervous system falciparum, which is obviously incredibly dangerous. However, his malaria screen was negative, just to
Good.
reassure you. However, a doctor the day before had done a lactate dehydrogenase on him,
Uh-huh.
953, and a
Uh-huh.
ferritin, which is over 400.
Right. Well, ferritin's is an
It
acute
is.
phase protein,
It
so
is.
that goes up all the time. LDH,
Absolutely.
we're thinking about lymphoma again, aren't we? So we're back in lymphoma land. I think we need to get all of our infectious disease screens done. We can do that
Excellent.
concurrently. And LDH is not diagnostic of lymphoma. It's
No.
part of the evidence that you adduce when you're trying to work out whether there's a
Yeah.
hematological problem going on. So it's useful to know.
hmm Yeah, absolutely. It might be a bit of a red herring as well, hadn't it? But
Yes.
it's one of those things. When I saw him and I was on the post-take ward round, I had the same thought as you. I was like, really? What am I going to do with that now? I was like, don't tell me there's a D-dimer. Please tell me somebody hasn't done a D-dimer on him. There was no D-dimer done on him. But it's that sort of thing, you've got everything. You're like, okay, I'm happy with my plan. And then somebody throws you a curveball and you're like,
Yeah.
what am I going to do with that curveball? Do I need to still go down that lymphoma route? Do I need to speak to hematology? Do I need to do that CT thorax abdo-pelvis, along that route? So, where's your money on? You've given me loads of diagnoses here, Ben. You've gone lymphoma,
Yeah.
hematological malignancies.
Yeah.
You've gone viral hepatitis. You've gone EBV, CMV, and you mentioned
Yeah.
malaria.
Yeah.
If you were to risk stratify them in order of probably most likely to least likely, what would you do?
I think at the moment I'd lean more towards infection,
Okay.
just because of the travel history,
Yeah.
the rather sort of subacute onset, 12 days. That would be quite dramatic onset for hematological malignancy to present in 12 days, although not completely unheard of. And the fever, it could be a bit of both. The CRP is only 28, but at the moment I would be I feel like that's the more likely diagnosis based on this information. I wouldn't be
Okay.
shocked if it was a malignancy, but
Mhm.
if I had to put money on it, I would go infection first of all.
Yeah, absolutely. So, and I agree with you. That's what my thought processes were as well,
Yeah,
because pretty much the same as you, the fever, the headache, sort of the 12-day history of that and the recent travel, conscious in the background of this LDH and these lymph nodes, which could straddle both pictures. But we had his EBV screen back, which was normal. CMV was negative, HIV test negative, and hepatitis screen came back. And one of their hepatitises was positive.
go on then.
Which one would you like to go for? A, B, C, D, or E?
um, A.
Yes, well
Yeah.
done. Well done.
So A, fecal oral route, quite
Excellent.
acute onset. Can I ask a really weird question? You said he was a smoker.
Yeah.
Has he been smoking or has he been off his cigarettes the last few days?
I didn't. Well, he hadn't smoked. He'd been in hospital for 1 or 2 days. He hadn't smoked in hospital. But
You know how sometimes the weirdest bit of trivia just lodges in your brain that does no benefit in exams or anything in your medical career, but for some reason it
yeah,
sticks there. I remember distinctly in a lecture at medical school writing this down. One of the signs of acute hepatitis A infection is a sudden distaste and intolerance for cigarettes in smokers.
I wonder if that's actually true.
It's
I
stayed with
love
me
those sort
for
of facts.
25 years. I know, and it just stuck with me. Maybe I'll look it up after this, but that you said he was a
Ooh.
smoker. But that'd be lovely if that kind of was true. It's kind of nice to have little trivia like that actually works out and makes us look a bit wise. But acute hep A, yeah. So I was going to say fecal oral route. He's contracted that, and he's come back, and he's got an acute hepatitis picture,
Mhm.
an acute lymphadenopathy reaction,
Yep.
self-limiting condition.
Yep.
So he just needs some conservative treatment and then serial LFTs to make sure that things are sort
Yeah.
of melting away over time.
Exactly, and that's exactly what we did. Um, he had basically the care is supportive. So although he's using his Rocaine, he wasn't drinking very much, and he had some IV fluids. We gave him some pain relief for the headache. We didn't scan his head, and we didn't do a CT thorax abdo-pelvis, but we did do an ultrasound scan of his abdomen.
Mm.
That was done before the hepatitis results were
Mm.
back because hepatitis results don't come back within a few hours. They take a little while to
Yeah,
come back.
yeah.
However, we were pretty happy from the history and the examination that we thought this was viral. So we thought,
Mm.
actually, we don't need to do that CT because I'm happy that this probably isn't lymphoma. And we don't
Mm.
need to do the CT head because I'm not convinced that this is a space occupying lesion or
Mm.
a pressure headache. So it all sort of fit the picture. But quite it's not something we see very often. We see a lot of jaundice, and normally it's biliary jaundice, and it's either they've got a gallstone, they've got cholecystitis, cholangitis, but we very rarely see a good going hepatic infective picture in acute medicine. And it felt like a case that I could really get my teeth into and really think about it as well. Um, and really focus on being a good general physician. It felt like that type of case. And I think we've just talked through that, going through your thoughts, and that was really, really helpful. And it's good to know that we were on exactly the same lines.
Yeah, and you managed to avoid a painful biopsy and unnecessary tests for an 18-year-old who
Exactly.
presumably would not like to go through that unless they're absolutely necessary. I think if your infection screen all came back negative, then you have good grounds for organizing an ultrasound biopsy of a nice amenable lymph node, maybe in the neck
Mm.
or something, and then following that with your hematology colleague. But yeah, that sounds like a really good a, a good diagnosis that was made, which benefited
Mm.
the patient. And as I said before, LDH doesn't diagnose, and the LDH just means there's a lot of cell proliferation,
Exactly.
which you
Yeah.
do see in hematological malignancies, but it's not diagnostic. And other things like B2 microglobulin and things like that,
Yeah.
there's not a diagnostic blood test for lymphoma.
Yeah.
But there is a diagnostic test for hepatitis A, and you got it.
Exactly. Yeah. And I think what it also shows is sometimes what I love about acute medicine is we get to see people at the front door where there's no history, there's nothing, there's no preconceptions. There is a bit of bias sometimes from previous history taking, maybe an ED, but in this situation, there was very little. And I had a really interesting conversation with a colleague last week, and somebody had, not in the most polite way, had said to him, you missed this diagnosis. And he was
You
like,
said that to them.
no, somebody, I was having a
Oh,
conversation with a colleague
yeah.
and somebody had gone up to him a few days before and said, I just want to give you some feedback. You always dread that. I saw a patient, but you'd missed this diagnosis. And he was like, he came to me and he was like, it was really difficult because I may have not thought about that diagnosis on admission, but 5 days down the line, when you have all of the investigations, everything back, 5 days of vitamin time, actually, it's a lot easier sometimes to make a diagnosis 5 days in the admission than it was in the A&E department or in the admissions unit when you've got very little information.
Yeah. And even harder in the GP surgery. I mean,
Really
I
difficult,
always
yeah.
say hats off to the GPs, because they are, to how I would feel, flying blind. They're making diagnosis using their heads and their hands,
Yeah.
laying hands on the patient, old school
Yeah.
medicine. I get presented a patient who's already had all the blooming tests done, and
Yeah.
I sit in the easy place. And then, maybe the downstream ward or ITU, they're seeing a patient who they got all the test results and they've seen a few days of treatment go wrong or go
Yeah.
right, and then they can make another
Exactly.
judgment call.
Yeah.
So it's I mean, and you're absolutely right. It is what the fun part of gen med, of acute med, is making diagnoses. But I think it's also the time frame, because you can sit in a clinic, a specialist clinic, and you can still have that job satisfaction of making a diagnosis. You
Yeah.
maybe work at a liver clinic or a neurology clinic. You get patients referred to you, and you do tests and you make a diagnosis. And that's very similar. The thing is for
Mm.
us is the time frame.
Yes,
We
exactly.
we like results same day.
Yeah.
We want to see what's happened to that patient overnight and then have another look tomorrow.
Yeah.
And that's where our job satisfaction comes from. And for me, that's the fun of it,
Mm.
saying, let's try this today and then we'll see what happens this
Yeah.
afternoon, what
Yes.
happens tomorrow, rather than I'm going to book a bunch of really important tests and I'll see you again in 6 months or 9 months, and then we'll see where and that would work for other people, but not so much for me.
Yeah, exactly. Absolutely. So, to end the story, the gentleman got better in a couple of months. He was followed up by our gastroenterology team. And he, yeah, made a full recovery, which is good. There are a very small proportion of people with FA who do have acute liver failure, but I think it's a very small number of people. So yeah, it's a nice ending to the story.
Shall I look up now for listeners whether or not hepatitis A gives you distaste for cigarettes? And then that would be a really cool learning point for the session. Bear with me.
Yeah, absolutely. It's amazing when you're at medical school how you remember things that follow you on throughout the whole of your career that you think may or may not be important, but occasionally I'll pull it out the bag. Causes
One
of
day.
causes of clubbing. ABC. A. Oh God, now I
What have
forgot.
you done? You've opened up Pandora's box.
I've opened up Pandora's box, exactly. But what's really interesting is we do still always look for clubbing. And I always look for clubbing in the toes as well, because often if you've got clubbed nails, you've got clubbed toes as well, haven't you? Which is always interesting.
It is true that people with hepatitis A infection can develop a distaste for cigarettes. The phenomenon is attributed to liver inflammation caused by the virus, which can alter taste perception and cause aversions to certain smells and flavors, including cigarettes. Ooh.
Wow. That is a fantastic bit of
I
knowledge.
can't believe
Thank
that's
you.
been lodged in a little synapse in my brain since 2002 or something, and it's finally come to fruition on
Gosh.
this very day. Big day for me.
But it just goes to show, though, how important, even small interactions with students and doctors may have in their future.
Mm.
So it might just be 1 to 2 minutes and it can have, that's lodged in your brain. And I bet you can picture where you were sitting as well when you had that information.
And the pen I was using
And
to
a
write
pen,
down. Yeah,
exactly.
I can see the page, my notes. It's really weird.
Strange, isn't it? So, three key learning points aside from the cigarettes.
Okay, so the notes I've made down, it's always nice to revisit that sort of pathway between hematological and infection. It's really, really common that you're trying to make that kind of judgment call. And it's always good to think about what your screening tests are and how you're going to eliminate one or the other. Usually the time frame for infection, you tend to get results faster than you do for hematological diagnoses, which is usually biopsy driven. So you usually forms the way that you rule out infection, then move to hematology in general, because that's just the way we tend to get results back. It's important to remember there are no specific blood tests or serological testing for hematological diagnosis. There's lots of supporting evidence. For example, if their white cell count is 60, that's probably going to be, that may well be a leukemia rather than a toxic granulation acute infection. But it's all about adducing evidence and making a judgment call clinically rather than saying, hurrah, this one blood test has come back positive for lymphoma. We now know what we're treating. You've got to organize the biopsy. So they'd be my first two. And we'll say for the third one, it's always nice to operationalize liver dysfunction into prehepatic, intrahepatic, and posthepatic. It's just a nice way of breaking it down and thinking about it and helping you tackle it and make a plan of diagnostic attack.
Excellent. Thank you so much, Ben. I hope everybody who's listening has also taken away some key points from that great case. Thank you so much, Ben. As always, it was a great, great podcast. Thank you to everybody out there for listening. Downloads are increasing. We are nearly at over 500,000 downloads. No, sorry, 250,000 downloads. I've really increased our numbers. Quarter of a million downloads. So please rate, review, and share the podcast with friends, colleagues, and anybody else you think would want to listen. Thank you to everybody out there for listening. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.